Mr. Anthony Ward will start this workshop.
Thank you. I'm going to demonstrate to you the percutaneous insertion of an iliosacral screw at S1 level. Now, what are the indications for using such a screw? It's for the closed reduction and fixation of a sacroiliac joint disruption, a sacral fracture, or a fractured dislocation of the sacroiliac joint, a crescent fracture. If it's a type 3, if the fracture line in the crescent is very posterior, then we can insert a screw into the free fragment of bone. Okay. Now, preparation for the case, you must study the X-rays and the CT scan carefully, because you need to plan from the CT scan the level that your screw can safely be inserted, where the best bone corridor is at S1 level, to avoid hitting one of the structures outside of the bone. Okay, and we'll show you a little bit of that in a minute. So once you've planned on CT where your screw is going to be, we then have the patient positioned supine, classically. You can do it prone, but with a polytraumatized patient, it's better to do the patient supine. Then we are going to screen the image intensifier, but we should make sure we've got a urethral catheter in the bladder, and I'll explain why in a minute. Okay, so we start with the patient supine. We often have a saline bag under the sacrum to lift the sacrum a little bit higher, because when you're putting your screw in, you often have an angle at the table. So the patient's high enough, and then we're going to screen. So the first screen is an AP X-ray of the pelvis, just to check the alignment, see whether we need to do a reduction in the vertical plane or not. So the AP screen, the first view is this one on here, which is showing the symphysis pubis and the lower part of the anterior pelvic ring, and we would move that side to see both hip joints as needed. And then we're going to move up to look at the proximal femur. Now we can see a better centered image view of the whole of the pelvic ring. And that gives us an assessment of any internal rotation and potential vertical displacement. So then we go to the next view, but we don't see the sacrum very well. So we need to now center the image intensifier a little bit higher on the sacral. So our third image is the other way. Yeah, it would go up towards the top of the patient so that we can see the top of the sacrum. Good, and there we can see the midline. It's a well-rotated X-ray, the spinous processes. We can see the S1 foramina there, and we can just about see the alar of the sacrum superiorly on that side. Good, so we're going to be operating on the patient's left side, that's over there. Good, and then we're going to screen and this is the point where we would do any stress X-rays if we felt they were necessary to check the stability. Then we're going to do an inlet view. Inlet. So that's the last top image. Yeah. We took these images earlier to speed things up. And there's our inlet X-ray. And we're looking for the promontory of the sacrum anteriorly. You can see that nice and clearly, the anterior border of S1. We can see the recess of the alar on both sides at that point, just higher up, yeah, there we are. And we can see the posterior part of the sacral body just about there. Just below that is where the vertebral canal is. You can see that arch. So we know we want to be aiming for the middle of the sacrum on that view, about there. And how we orientate the screw depends on whether we're closing a partially disrupted open book, in which case we need to have the screw relatively transverse to close the front of the joint. Or if it's a complete sacral disruption, we want to be angling the screw more anteriorly, from posterior to anterior, So start more posteriorly, yeah, and angle anteriorly like that to bring the ilium anteriorly and medially, usually to close that. Good. And then we're going to go to the outlet view. So if we can rotate that way. Now what do you do if you cannot see these views? You take your X-ray, particularly on the outlet view, and it's just all gas and bubbles. A good tip, you can either squeeze on the abdomen a little bit, that will move the gas about a bit, or you can put about 350 mils of saline into the catheter, and that distends the bladder, and that will push the bowel away, and you'll be surprised how much better a view you can often get at that point. But clearly, if you cannot get good views, you cannot proceed with the operation percutaneously. It wouldn't be safe. So here's the outlet view, and you can see that we change the angle as needed to get that view. So we can see the foramen of the sacrum nice and round, and particularly on the other side it's a bit more clear there. Can you see it's a round hole? That means you're looking up the canal from front to back, so that if the screw is not in the canal on that view, it cannot be in the canal in real life, because you've angled up the canal. The nerve is sitting right in the middle of that from back to front. And we also look at the level of the L5S1 disc, the end plate, and then following out laterally back towards us there's the alar. So we know we've got a corridor of bone between the alar and the top of the sacral perimeter. So we know if we put a screw in about that position, we should be relatively safe, depending on what we decided from our CT. Whether it's better, safer, higher or lower, depends on the axial CT images that we had earlier. Good. So we're happy. We don't need to do any significant manipulation of the fracture, otherwise we'd do it now. Now we're going to go to the lateral sacral view. Now I apologise, because this isn't an operating table, it won't go up and down, so we're having to use the image intensifier the opposite way to normal. Normally we would have it rotating under the table, so it's out the way, and it would come up here. But because the table won't go any higher, we're doing it upside down. So this is coming over the top just for our demonstration. That will allow us to get the image intensifier low enough to see the sacrum. Now this view is the key. This is the most important view for safe insertion of your screw, because it's going to define our entry point, and we're going to check on the images as we insert the wire that we don't proceed too far anteriorly or posteriorly. The other way, yeah. And we orientate the image so that it's the same way as we're looking at the patient. So we'll need, yeah. So it'll be the other way, because ideally we want the image so left is right and right is left, so that what we see on the X-ray is what we see operating here. Otherwise we've got to work backwards, mirror image. So if you can put that supine, that's it, back again. And can we reverse the image? Or not? Okay, we'll see if we can, but if not, we can do it this way around, but it's just, it's not quite so easy. Yeah, so, that's the... Okay, it doesn't matter, we'll carry on. If you could step back from the image. Yeah, thank you. So the next stage, because we'll probably be able to do it in a second, so we get that where we think it's roughly right with the patient in the supine position, and then we're going to screen. So can we go live now? Can we screen? Screen? Yeah. So we need to come down, keep going down and down and down. So can we reduce the height of the image intensifier? Okay, good. Here we go. Now let's keep going lower. That's good. Towards the floor. Okay, and then that's good. Now, can you rotate that image? That's it. That's good. Stop there. And then, can we reverse that image? Can we put a mirror image up? Yes, perfect. Thank you. Now that's orientated to the way I'm looking at the patient. Now, can we screen and again. Now, can we rotate the image so that wire is vertical? So it's vertical. Thank you. Stop. Back it. No, back. Stop. Okay, that's near enough. Good. So now we know what is vertical when we're planing out. So what I would do is mark where this wire is on the skin. So, sorry, show me again. Good. And again. Good. So that's near enough. So that's our line. That's our vertical line. And then if we work our way up the vertical line, show me that image. Good. Now, to check that we've got a true lateral view of the sacrum, we need to look at, if you could screen that again. And will it screen live? Yeah, so we need to see that line there, which is the pelvic brim. And we need to see two lines superimposed. And that means either rotating the image intensifier or the patient. And the second thing we look for, can you screen live again? Screen live, keep it on, is there. Can you see the greater sciatic notch? There are two separate images, and we want to rotate that till they are aligned. And then providing there's no pelvic displacement. If the hemipelvis is displaced, we have to ignore that. And the most important one is that, now we have problems with the cadaver in that we can't rotate it, and we have problems with the image intensifier because we can't rotate that any further down. So we're going to accept what we've got, knowing it's not perfect. Now, to get the entry point, if you could screen that live for a second. And again. Okay, can we improve the contrast a little bit? No, the contrast. Yeah, okay. So, see, that's not bad. That's the alignment we want. If I pull it up towards me a little bit, and again, there. So we're just below the promontory, the sacral, the pelvic inlet, and we're right in the middle of the vertebral body. Do you mind showing the vertebral body and the S1, S2 disc space? Yeah, we need the image on the other side, don't we? Oh, am I looking at the wrong image? Just screen that live again. Yeah, we're looking at the other. Sorry, can we have a look? Can we have the camera on the other image? Yeah. Yeah, we need the camera on that image. Good, okay. So our entry point, so let's do it again. Show me the entry point, screen that live for me. And live again, keep it on. Keep it on. There, good, and screen that again. Okay, so that's two anterior in the sacral body. If we put the screw in there, we will come out the front of the sacral alar. We'll have an in-out-in screw. So we just need to move a little bit inferiorly. And because we've got that aligned, we know that all we have to do is drop down a little bit more to there. Show me again. Good. And just back a tiny bit. Hold on. So just go approximately, and again. Okay, so I want to be just below that. So I'm now going to mark that spot. And we're going to put our a knife, thank you. You can make either a vertical incision or a horizontal. I tend to make a vertical incision because I want to be able to move orientation of the screw anterior and posteriorly, having defined its level. So we think we want to be about here, and it's always further back than you think. So through the skin, through the deep fascia over the gluteal muscles, but be careful not to go too deep with the knife because you can hit some blood vessels. And then we do blunt dissection with a pair of scissors. Any scissors? Mine is vertical, yeah. I use a vertical incision so that I can move in that plane. So, in we go, straight down till I touch bone, and then I can, sorry, it's still a bit frozen inside. Oh dear. Because normally you can move this around so you can feel the fossa of the posterior ilium, and then you know you're roughly in the right place. Then we open the scissors to spread the muscle a bit, and now we're going to insert a guide wire on the soft tissue guide, and then we're going to recheck our position.
Could you please show us the tip of how to get the exact inlet of the, following the anterior border and then marking the line in front?
Sure, I'll do that at the end. Yeah, we'll finish and then we can answer any questions. So if you could show me that now, please. Screen that, please. Yeah, so that's not bad. So I'm just a little bit too low and anterior. So if I go in about there now, and a little bit further posteriorly, and again. See, that's not bad, is it? We're below the promontory. So if I just get have we a mallet by any chance? That's it. Okay, so I tend to start with a mallet because it tends not to slide off the bone. Good, and then if you can show me that again. Then screen. Yeah, okay, so we're a little bit anterior, so I'd like to move that a little bit posterior. And again. Yeah, okay, I'm going to go with that at that point. And show me again. And again. Okay. So that's a little bit low, so let's leave that one there and put another in just above and behind. And in real life, the tissues are more malleable than this, and you can move your wire more easily. Okay, and screen that for me, please. Okay, so that's a little too far back, and again, and a little bit more. Yeah, good. Okay, I'm going to buy that. So do you want to show the landmarks now? So we're below the promontory, which unfortunately there are two superimposed. We're not in a true lateral view because of this. But if I move, let's screen that again. Still a little bit off. You can see there are two lines, but you can see I'm in the middle. You show the anterior border of S1, anterior border, that's good. Show the posterior border of S1 where the canal is, just in front of that. There you go, that's the canal there. So we're pretty safe. We're a little bit low, so we're going to deliberately aim uphill a little bit as we insert this wire. And you can make a decision whether you want to angle it forward, superiorly, or stay horizontal. And with this technique, it's best to try and stay horizontal if you can. Okay, show us that. And again. Yeah, okay, so that's heading posteriorly. So, and again. Good, there we are, that's better. So, and I fire this in till it hits some resistance, which is usually the sacroiliac joint. So one final screen. Excellent. So that's heading in a good direction. It's not true lateral, so if I was putting a transsacral screw in, I'd have to adjust it so it was a true lateral. But because we're only putting a unilateral iliosacral screw in, that will be fine to be in the body. So now if we could switch back to the Now again, if I was confident with the alignment on the other views, I would actually insert this wire a lot further before going to the other views. I'd go to the level roughly of the foramen. But for the demonstration purposes, I think it'd be better if we now go to the inlet and outlet views to check on both those views we're heading in the right direction, because we haven't got a true lateral sacral view. Okay, and then I need to fire that. I'll take the other wire out. Power, how do we... Yep. Thank you. Okay, now if you can come in for the inlet and outlet x-rays. This, yeah. We'll do the outlet first, that's good, because that will give us our height and show us the foramen. So we made a mental note that we were at 40 degrees. Oh, the other thing I didn't mention was, if you can show them on the image, the sacrum, the anterior border of the S1. Oh, it's gone. It's all right, doesn't matter. We'll come back to it. Yeah. Now we're upside down, so can we go the other way up? That's good. Okay. So I'm going to take that first wire out because we know it was too low. And you see the main guide wire we put in is now at the sacral joint. I felt that resistance with the mallet. So show me again, please. Now that is a good direction. Can you see that is going to be above the S1 foramen and it's well below the promontory. So now can we go to the outlet view? To the inlet view, that's it. And if we're happy with that, we're now going to introduce this wire all the way to the body of the sacrum. The strongest bone is medial to the alar, medial to the foramen. Yeah, and I see, and show me that again. See, and that's a good alignment. That's going to be in the body of S1, just behind the promontory. Now, if I wanted to, I could aim it a little bit more anteriorly. It's on reverse. How do we... both together, thank you. Yeah, it's just, I just wanted on. Thank you. Brilliant, thank you. That's good. Because it's a threaded K wire, we need to have it going in the right direction. Okay, and now screen that again for me. That one, yeah, so that's heading okay, isn't it? It's just heading a little bit posteriorly. So if you bend the wire, it will actually turn that way. So you point down and bend the wire. As it spins, it should go further anterior. And again, please. Yes, there we are. So that's following a nice track. And again. That's good. Now, can you change that angle just a little bit? Take a bit of that tilt off, just to be sure we're not too posterior. That's it. That's enough. Just a little bit. Yeah, okay. So we think we might be a little bit superior, a little bit posterior rather. But I think for the purposes of this, we will just carry on. So if we were worried, we would put another K wire in parallel to that one. There is an additional piece on the on here that you can attach, so you can put in a parallel wire, and we just put in another wire beside this one and extract. So now if we can go back to the outlet view, because we need to just double check that we haven't deviated. Now, if you had to do a reduction of a fracture or a sacroiliac joint, you would stop the K wire at just short of the sacroiliac joint, just there. So that you'd stop the wire at that point, and then use your guide introducer to manipulate up or down, and you'd have an assistant pull on the leg to manipulate down. So if you think to come this way, that way, if you have this arm close to bone, that will act as and if you need to close the book more, an assistant can compress the pelvis manually. Okay, so we've got the outlet view, and up towards it. And I know some people mark the floor with the image intensifier so that it helps the radiographer know when he comes back to the view what level he should be at. Yeah, they are, so that's good. So that's above the foramen, and it's heading superiorly rather than inferiorly, so the other side is safe. So I'm now going to insert this until we get beyond the midline. And again, please. Good. And again. So that is about 1 centimetre longer than I want the screw. So we will take off a little bit when we measure the screw. And I do that because when you put if you have a cannulated drill, you can, if you're not careful, over drill the guide wire. So, depth gauge. So let's measure the length of this. We're going to put in a lag screw because we're closing an open SI joint. Okay, so we've got a 90 screw. It's measuring a bit longer than that, so the screw will be short, but we put in the length that we want. Normally we would use the... Yeah, 110, yes please. 110 would be good. Normally we'd use the cannulated drill now, and I use, because these are self-drilling, self-tapping screws, I only drill as far as the sacroiliac joint. So we just go through the dense bone of the sacroiliac joint. Good, there you go. And not drill too far on the wire. That's good. And if you stop the wire just short of the just short of the sacral foramen on the other side, I'll show you what I mean. And again. Yeah, and again. Good. And again. Then you're safe. You know you can't be hitting anything on the far side if you're worried you're close to the foramen. So we're now going to put the screw in. And the screw comes with a washer because we want to have a lag effect to close or compress the sacroiliac joint or a sacral fracture. It's down to bone. And this is important why you have to spread the muscle, because the washer will get stuck, held up otherwise. And then once we've got partly in, we stop and screen to make sure we're not pushing the guide wire further through. So no, fine, so that's looking good. Yeah. Some people use power, but I think it's safer to put these in by hand, because if you go too far, you will cut out the screw. And you want to get the feel for when you're down at the bone. As soon as you feel any resistance, stop and screen it. Okay, and then let's screen that, please. Good, there we go. See, that's a safe screw above the foramen. Good, and let's screen that again, please. That's going slowly. Sometimes the screw needs a little tap to re-engage the threads if they start to cut out. Now, if possible, use a long partially threaded screw. Some of the systems have 20mm or 40mm options. And so I would put in the longer partly thread. I'd put in the 40mm, or some systems have a 50mm part threaded component, because you'll get a better grip in the bone. Now, we didn't plan this, but if we'd planned to put a second screw in at S1, this would be the ideal position, because we can put a screw in above the level of this one and still have room. So I'm starting to get some resistance now, and we know the screw is roughly as long as we measured. So the next stage, can you see the condensation of bone on the lateral side of the ilium, where the screw head is? Further back, that's it. So we're looking to see that washer tilt. And show me again. Yeah, so that's just starting to cut in the bone. That's too much. It's an osteoporotic patient. So, can you come over the top? Just, that's good, right? Just to rotate. Oh, well, do it on the other view. That'd be. Yeah. Okay, just come. So we can't go any further that way. Yeah, we can. Good. So come back to the AP view. I prefer just a slight outlet view. So come vertical. Yeah, we just need to come vertical. Yeah, that's good. And now screen that for me. No, come back. Can you? We want that rotation back. Yeah. No, I want it back. 10. Good. Stop there. That's it. Now we've deliberately brought the rotation over the top because we want to look down the lateral ilium. So let's screen that, please. And I think that's probably a bit too much. So come back a bit. Take some of that rotation off. We're trying to see the condensation. Yes, there we are. Now, and again, please. Good. Now, so we want to see that washer up against the lateral cortex, but to check it's the right one, I take the wire out, and I'm now going to put the screw in onto the head of the bone and feel the bone around the head of the screw. Yeah, and I can feel, now screen that for me. Come towards me. Yeah. Good. So there's the washer, and again, yeah, it's frozen, so I can't move this, but I'm essentially feeling the bone beside the washer to check that it matches, and then I know the screw is in, because I had one case a couple of years ago where we left two screws about 1.5 centimetres, 2 centimetres out of the bone because the washer got held up and we didn't recognise it from the standard view. So we always do this now. And show me once more. Yeah. Okay, so we'll see if I could move this around, I'd screen it live. So that's it. So that's one screw in. Now we need to check the inlet and outlet views for our final pictures. Back to neutral. We did a study, including post-operative CT scans, to see if we could detect any malpositioning of the iliosacral screws. And the risk of malpositioning is very low if it looks good on all the views. But even if it looks good on all the views, there is a small chance the screw will be malpositioned. So we routinely do a CT scan post-operatively just for the sacroiliac screws. And then I think we're good. So you see that's nicely in the centre of the body. It stops just short of the sacral foramen on the other side because the bone further out is weaker. We don't need to go any stronger further than that. And then to the outlet view. Yeah. So we would save that view. We would save the outlet view. And then we would do a final lateral sacral view to be sure. Yeah, and that looks a good view. That's a good screw. So now we need to do the over the top, the lateral sacral view. Yeah. Now, has anybody got any questions while we're repositioning? Put a second screw. S2 screw. Okay. We'll see that now I'll show you on the lateral sacral view, but we do exactly the same procedure and we start with the lateral sacral view to get our entry point. Now at S2, it has to be a horizontal screw. It has to be a level screw. You can't angle it because the bony corridor is so narrow. If you look at a CT at S2 level, it's always transverse. So S2 level, we need the screw to look just like that on the image intensifier. Once we put the wire and the screw in, if it's, yeah, it'll be out. Good, so if we can come over the top. Any other questions? Inside of the body. At S2 you can't. S2 you cannot, because S1 overhangs S2, you cannot see clearly. You have to rely on the lateral sacral view and the outlet view. Outlet view to check you're between S1 and S2 foramen, and then the lateral sacral view. Now clearly, if on the inlet view it doesn't look anywhere near where it should be, then that's a problem. But if it looks so it should be where it is, you still can't be certain it's right without doing the other views. Just down towards the floor a bit. Yeah, and drop down. I'm sorry, it's harder to do because this is all upside down. So up towards the head, towards the floor a bit. Yeah, down towards the floor, that's it. Yep. Good. Now, if we could swing that image round, increase the... Good, and swing that round. And then let's take that picture again. Oh, sorry, yeah, okay. And show me the image. Okay, and then show me it again. And again. Yeah, and we'll take the K-wire. I just wanted to be sure it was right before I took the K, because once you take the K-wire out, it can be very difficult getting it back into the screw. So if we're happy on all views that it's in the right position, we're good. And then, excellent. So show me that, please. Okay, and I'm just trying to rotate the patient so we get those two promontories at the same level. And again, it's the other way. And again, show me again. And again. Good. So can you lighten the contrast so we can see? Good. So now you can see that screw is in below the promontory, below the pelvic brim there. It's above the S2 disc, the rudimental disc, which is just there. It's anterior to this spinal canal, and it's posterior to the anterior border of S1. So that is a safe screw. Yeah. Now, if you're doing S2, you do exactly the same procedure, but aim into the bone just a little bit lower, which I can... You probably need another incision, but we will see. Just show me that, please. Yeah. And again. Yeah, that's enough. And then show me that. Yeah, that's not bad. Hold on, don't screen it again. And again. And just a bit. Yeah, and again. Good, so we just want to be a little bit more distal than that marker to be sure we're in the middle of the body of S2, and then we can fire a horizontal screw. No, I would then go to the outlet view to check that we are not too high or too low as we put the wire in, but I'd start it on this view and go, a couple of centimetres in before checking the other view. Thank you. Yeah. So we're running out of time, so I think we should stop there. Thank you.